be able to take care of this population. How does it work? And then we keep saying, now the number of doctors in this country has increased, the number of trained nurses has increased, the number of clinical officers has increased. I agree, but how many of them are even in government hire? They are very few. We have only about 26,000 nurses in this country who are actually working in the civil service, but we have about 80,000 nurses out there. But the government cannot harness and put them in place to work because they don't, we don't have a budget for them. Now we're going to counties. We have had governors making claims that I have 80 doctors in my county, I don't need them, I only need about 20 or 5 or what. These people are not even looking at the logistics. Number one, what is the WHO recommendation? I still come back. It is 1 doctor per 1,000 population. So if you look at the size of your county and you make those figures, does it make sense? Okay? And one of the reasons, by the way, historically, if you look to some Western worlds, if you're in private practice, you're in private practice. If you're in public service, you're in public service. But the person in private practice and the person in the government, all at the end of the year make about the same amount of money. Here in Kenya, it's not the case. So if you go into public service, you're going to make less than 1/10 of what your colleague in private practice is going to be able to make. And that's the reason why this concession had to be made that allow them to have a part-time private practice, right? Now, if we're going to take that out because the governors want you in the facility 24/7, then they're going to actually have to improve the pay. And what is that going to take it? Astronomical figures. Right now, what are people talking about? Cutting the wage bill. Who is going to agree to pay this public servant that much money? And when you're all lumped and told you're a public servant, you should be paid the same as other people in your job group. The other people in my job group work 8 to 5, Monday to Friday, and they go home. And if we go to government offices, we even know how much less those hours actually get down to. Now here I am on call. We have facilities where, people don't actually even see the concept that when you talk about doctors or nurses, or you're not talking about a lump. You have various cadres even in that category. You will have the medical officers, you will have the specialists. If you're the only gynecologist in the entire county, for example, it means that where the hospital where you're based is where all the patients who require specialized services are going to be sent. Which human being is going to be able to take care of a county of, let's say, 800,000 people, being the only gynecologist working around the clock, and you expect them to take home 150,000 shillings a month and be very content that I've done my job? Because they'll never sleep, they'll never eat, the children will never see them, and as I said, at the end of the day, irrespective of our profession, we're still human beings.
Absolutely. Wow. Nelson Guga from Nairobi says, a brilliant doctor in the name of Nelly Bosire. You have talked so convincingly that any government worth its salt should listen. I support you. Governors are meeting today.
Yes.
To discuss the whole issue.
Yes.
Are you aware of that, and do you think at the end of it there will be hope?
We're aware there's a meeting going on. We are also not expecting much, because from all indications that we have, we didn't even start talking to governors about this issue of devolution today. They've been in office for the last 8 months. For 8 months, even as a union, Kenya Medical Practitioners, Pharmacists and Dentists Union, we have approached our governors at various levels. There has not been much interest. I don't know whether it is for just the issue of control, that we want to be in charge of the sector, or because if they critically looked at the issues that are involved, then if I were a governor and I had to deal with the complexities of the health sector, I would rather leave it at national level. But I would have the opportunity to push the national level to actually take care of my county. You see, perennially what has happened is we have been serving the nation from national level, and there are areas that are seriously disadvantaged, and the people there feel that by having county governments that we can be able to keep our doctors. Let me give you an example. Mandera County cannot be having more than 4 doctors right now as we speak. The nurses are getting even less because of the insecurities and all that. As these people exodus on a daily basis, even as a county, if you are a governor, how much do you think you would pay someone to stay? Especially when they know that this is a service where you're in short supply, and therefore your services are needed in many places. What would it take to attract? But at national level, there were incentives. Go and work in Mandera for 2 years, you're guaranteed of a fully paid scholarship to go back for postgraduate. Right now, as we're devolving, we don't even have a structure for continued care. And whether we like it or not, when you take me to school as a specialist, you're not doing me a favor. You're doing the people I serve a favor. They are the ones who require my skills. Me being a gynecologist today, I am not going to be able to deliver myself. I'm still going to require a gynecologist to deliver me. So you're not really doing me a favor, you're doing the entire country a favor. So if we're not looking at issues of training, there is no structure for that. There has been a structure. It may not have been the best, but we were looking at ways of improving it together with the ministry. But if there is nothing at all, there's a problem. Number 2, internship. You come out of medical school, you must intern for a period of 1 year. This is a task that has been undertaken by both the ministry and the medical board, because for you to finish internship successfully, the medical board must be in the picture, because it is the one that ultimately licenses you. There is no structure for internship now. The county governors are going to say, we don't need those people in our facilities because we have enough manpower, you know. And then where do they go and intern? Because the board has designated areas and says this facility shall be a designated area for internship. If we cede the responsibility of the healthcare workers to the governor, and he or she does not comprehend the value of that to the bigger picture of healthcare in this country, then it's very difficult to run this program successfully. These are some of the things that we actually say the Health Act must be in place. It must address these issues.
Yeah. There's perhaps just two concerns here, sort of linked. This is Shadrach and his wife Rachel in Narok. They say, kindly I'm requesting all health workers, please have mercy on the sick people. We're not the government. Because tungewalipa nyinyi, acha Mungu aingilie kati ya hii strike. And then Bob from Nakuru also says, Madam, consider the truth. Why torture innocent patients? And yet there's a lot of corruption, health workers in health departments, billionant as you press for the rights.
I totally agree with them that yes, the innocent Kenyans are suffering. What I don't agree with is that they're looking at the wrong people. The healthcare workers are not the reason they're not getting treatment. It is the people they elected into office. Hold your governor accountable as to why your hospital is closed, because he is the one who wants to take over a responsibility without structures. Okay? This maybe is not just for, you're not only sick today. You're going to be sick for many years to come, and you're really going to need these doctors to be there. When these doctors will get frustrated working under that governor, and they leave this country, then I wonder what's going to happen then in future. Okay? We're just pawns in a game of politicians, and we're being wrongly used. What we are saying is that we don't want this to continue happening. We have had enough. Every time we go on strike, we have exhausted all other avenues, because you don't wake up and walk away from hospitals for the sake of it or for the fun of it. Children can miss school when teachers go on strike. They can always have makeup. When the patient dies, there is no time for makeup. It's that simple. And so we're going back to where we're telling these patients, we have seen the healthcare system worse than it is today. People suffered. Do we really want it to go back there? Because whether we want to appreciate it or not, a lot of steps have been taken to improve the healthcare. When we look at what we are calling level 5 facilities now have come a long way. People who have seen Machakos district level 5 hospital before and what it is now cannot begin to compare. Kisii level 5 hospital, this is a sign that actually, as much as we may fault our central government, which we have done severally because we feel they're not working fast enough for us, but they have been making small strides which additively are making sense. What we say, put a structure so that what has been done does not disappear. As it is right now, do you actually know we don't even have a provision, a legal provision for what should be called a county health facility? We need that framework. You cannot say that Kenyatta is a referral facility and you don't have a policy document that supports that, that says that as a referral hospital, what are you eligible to do? What should the Kenyans demand from you? You understand? The county health facility is the same. So perennially, because the health worker is the one in the hospital, when things fall apart in the hospital, who is blamed? It's the health worker. But what people don't know, that for that facility to run, The input of the health worker is clinical. Managerial, we have what we call the district health management teams, district health management committees that involve a myriad of people who are not clinicians. Those are the people who are responsible for ensuring that that person you talked about who should cut grass is actually hired and paid and should be working. Okay? Those people actually fall under the doctor, what we call the health administrative officers in the hospital. And these people are not clinicians. So the terminology that the doctor is the reason why the facility is failing, we live with it, but we know it's not true. It's very difficult to convince a sick person on the bed that you're the reason why there are no bed sheets. I mean that you're not the reason why there are no bed sheets, but we got used to it, you know. So what we are saying is talk to, because at the end of it's an issue of legislation. Who is responsible for legislation in this country? The same members of parliament that our Kenyans voted for. So has any Kenyan asked their member of parliament today, why should it take so long to enact a health act? Yet we see the Media Act passed just the other day, you know? How come that was so fast? Within a few weeks we heard about it, within a few weeks we were over and done with it. Now here we're talking about a health act and everyone wants to make it look like an insurmountable mountain. It is not. It is something we can sit down and do. It is achievable and within a very reasonable time frame.
Let me ask you this. Why is it that Kenyans are going to India in the hundreds? The other day I saw a guy whose wife had breast cancer. She died in India. Breast cancer is not a thing to take to India.
It's not.
Kidney problems. Dialysis are there, many in this country.
Yes.
Heart problems.
Yes.
Why is it that Kenyans are flocking to India for treatment, and we have private hospitals here which can do it, and we have maybe public hospitals? No. But why is it that in that hospital, that guy told me, there were 23 Kenyans in one hospital in India, suffering from various types of cancers? Why is that so?
There are various aspects to that. One, public perception. As Kenyans, we have a perception that anything foreign is always better. That is not true. Okay? That is definitely not true. We have very highly skilled people who can do exactly what's happening in India in Kenya. But this brings in the second facet, availability of resources. You go out there and everything is so fancy and so technical and robotic and all these things, and you think that because they are done like that, that they are better. Not always the case, okay? For example, Nairobi Hospital put up a beautiful oncology center. It has everything needed to treat cancer. The Kenyan who can actually afford to pay to be treated in that facility would rather take their money out of this country. The majority of the poor Kenyans who cannot afford those services are flocking to the government facilities, right? And the government facilities don't have much. When they go to India, they're not going to a private facility. A lot of the facilities, they are going to a public facilities or teaching hospital facilities, which is what the country has invested in. In Kenya, that should be the thing. Any first world, go to United States of America, some of the best hospitals, Johns Hopkins University Hospital is what? It's a university-owned hospital. It's a public facility. They invest in their public facilities. But if we keep giving a budget of 4% and 5%, where is the money going to come from? To turn Kenyatta, which is a central referral facility, at the same time a teaching facility, to that level. So as they go, they have freedom of choice of treatment. We cannot fault them for that. But sometimes we've also had very sad stories. Sometimes we know when your person is sick, you really want to try everything. Because it doesn't make sense for you to leave Kenya to go and have your relative die in India and then you bring a body back. That is something that you would have actually been advised from here, that our chances may not be so great. So instead of spending so much money doing this trip back and forth, let this person die among family, where they are comfortable, where they are surrounded.
Isn't it also true that those I saw another guy whose wife was diagnosed with breast cancer.
Yes.
She went to India.
Yes.
She was told, no, nothing like that. Yeah, okay. The other, there were problems, not that one. Why is that also here?